So morning, everybody. So thank you for joining. So we're going to just talk today about use of steroids during the COVID-19 era. And I'd just like to introduce my colleague, Joela Mathews. She's our neuroscience lead pharmacist and everything pharmaceuticals around MS. Is that correct, Joela?
Yeah, covering everything from the weird and the wonderful to the license.
To the license, or having to deal with us wanting to prescribe off-license products.
Oh, yeah, of course.
So you can see my screen. So as you can see, there's a question and answer box. We will try and answer questions as we go along live. So don't wait until the end. We'll try and make this as informal as possible between Joela and myself in terms of the question and answer. Just to say that I and Joela have got disclosures, so you've got to be aware of these disclosures when we discuss various DMTs, for example, and also to remind you that this has been sponsored by Roche, this particular one. Okay, so Joela, this is a question for you. Is there a COVID-19 risk associated with high-dose steroid use in MS?
So obviously any high-dose steroid is going to make you immunosuppressed. So if you think back to March when we knew very little about COVID, we as a nation and healthcare professionals were worried about any immunosuppression, increasing your risk of catching COVID and it making more severe. And there was that worry for anyone on any immunosuppression to then go onto the government shielding list, and everyone was on these lists, and either through the trust or the GP or through NHS England.
They just had a threshold though for dose, didn't they?
Yeah, and it had to be high dose. So we're not worried about those rheumatology patients who are on 5 to 10 milligrams of prednisolone. We're probably not worried. It's those high dose above 30 to 60 milligrams. And it's going to be those rescue courses. So in COPD, a rescue course, an MS relapse dose. It's not the regular doses.
Anyway, I'm just to say we have got data now. So this is now available on the pre-publication. So this is actually the second paper that's been put forward by the Italians, showing that people with multiple sclerosis who've had recent high-dose methylprednisolone within a month of getting COVID-19 had a 6 times higher risk of being admitted to hospital, in other words, having severe COVID-19, than people who didn't have methylprednisolone. And this, when I asked Maria Piersamani, this was not only for relapse treatment, but also methylprednisolone given to prevent infusion reactions. So we have data now, is no doubt that recent high-dose methylprednisolone is associated with a worse outcome. And so I think you've got to keep this in mind in terms of managing relapses and infusion reactions. So the big question is, I'm having a relapse, and we've got a lot of patients who don't want to come to hospitals to be assessed. And I think the big issue is pseudo-relapses. So we all in the MS field know what pseudo-relapses are. These are recurrent symptoms that are brought on by usually fatigue or infections or temperatures. And that's why our definition of a relapse has to be the appearance of new symptoms or the return of old symptoms for a period of 24 hours or more in the absence of a change in body temperature or infection. So this is why we always tell our patients who come in with a potential relapse to screen themselves for infections. And the infections don't have to be symptomatic. They could be bladder infections, for example. Okay. So this is one of the big issues. And I don't know if we've sorted out the ability to differentiate pseudo-relapses from relapses using virtual consultations.
And I think there is that issue. Some trusts have got patients that there's a steroid-seeking behavior, that they like that the euphoria associated with high-dose steroids, and they come back and say, oh, it's time for my steroid doses, because there is that euphoria and high that people get.
Yeah. I also want to point out that there are studies that have been done. This is from Martin Duddy in Newcastle, just showing that even when pseudo-relapses is the one issue, or people telling us they've got relapses to get steroids, but some people don't even report relapses. So in Newcastle, way back in the early, I think it was done in 2012, the study, a quarter of relapses weren't being reported by patients. So that's another issue, is people don't report relapses, which is not part of this discussion. So Joela, one of the things I'm wanting to study is the ability to test at home. We're trying to get a little project funded where we're using neurofilament levels. As you all know, neurofilament levels, which is a biomarker of axonal damage, and those levels go up with relapses or inflammatory activity. Can we actually get levels tested in people at home to see if they're having...
You mean like a finger prick test?
Yes, finger prick test, yeah. So the idea would be, if you're not sure, you don't have to bring them in because of the issues around exposure in hospitals to coronavirus. You actually send them out a little blood finger prick test, and they send it back, and you measure neurofilament levels. And this is just showing you an example of a patient who had very high neurofilament levels when they didn't actually have a relapse, no symptoms. They did have a cognitive relapse, but you can see the levels went up very, very high. So obviously, somebody who has a relapse and they don't have, raised neurofilament levels, you could possibly say this is a new type of pseudo-relapse. That's the idea. Yeah. I mean, we actually got I always put this particular patient up. This is a patient of mine she'd failed alemtuzumab. And she came in with this buzzing sensation on her buttock, and I couldn't find anything on clinical examination. And we scanned her, and we didn't find any lesions. But eventually she was so adamant that she had a relapse. We did a lumbar puncture, and we found very raised levels. So I do think this is possible as a treatment, as a strategy for detecting relapses, is by measuring neurofilament levels. So we'll see. And watch this space, everybody. Maybe in 3 or 4 months' time, when we've done our pilot study, we'll be able to tell you that you could actually arrange for them to finger prick themselves at home and send us the cards, and we'll be able to measure neurofilament levels and tell you if they were raised or not. The problem about this service is going to have to be a rapid turnaround, and that's the issue. Most laboratory tests don't turn around as quickly as we'd like them to. Joela, I know you're a pharmacist, but one of the things we always assume is that steroids are these miracle drugs. So how good are steroids in treating relapses?
I think they are not the best drug. Like a lot of relapses will self-resolve anyway. So actually, have the steroid added anything in itself to some patients? But it makes the physician, it makes the patient feel like, oh, we're doing something active. If you're given a placebo, you might get just an effect we don't really know. High dose steroids are going to have immunosuppression effects. They are going to have that euphoria. So there is the bonus of feeling good, even if you go through a relapse, and maybe that's what we're achieving. The evidence is, if it had to go through a nice appraisal, would it get through?
I don't know if it will, because I tell you what happens is all that steroids do, and this is now beyond doubt in terms of the evidence, it speeds up recovery. The ultimate outcome is identical. And so when you look at somebody at 6 months, the EDSS scores will be the same, but the people just get to their improvement about 2 weeks on average earlier. And so when you tell patients that all it does is speeds up recovery, a lot of them say, okay, I don't need steroids. I mean, there's no doubt that steroids work, okay? So this is actually showing you compared to placebo, this forest plot. And this is given versus within 5 weeks, so that we don't have any evidence that 5 weeks outside of a relapse make any difference. And so that's another important thing. All the evidence supports that you have to treat with steroids within 5 weeks of onset. Okay, but as soon as you go out to disability scores, when you follow these patients up, the treatment effect is lost. Okay. This particular one shows you when you randomize them at 1 week after, within a week of symptoms, and this is at 4 weeks after randomization, you lose the treatment effect disappears. So the treatment effect is early, speeds up recovery, long-term outcome, no difference. Okay. So this is the one that's definitely for the pharmacists. Joela, oral versus IV, what do you think?
Well, if I was being the cost-efficient pharmacist, I'd be saying oral is a lot cheaper. You don't need a bed. It's easier to give. Go with oral. It's available. We have licensed products in this country.
So we now have these 5 studies across various time points. They go back from 93 to 2015. And there is no doubt that there is zero difference between high-dose IV and high-dose oral. And, you tell patients that there's no difference between high-dose IV and high-dose oral, and they don't believe you. They always think the intravenous works better. and I tell you something, this is also healthcare system dependent. You know, in Germany, where you make money by bringing people into hospital and putting up drips, everybody gets treated with intravenous steroids in Germany. You know, in the UK, where we don't get paid for admissions and infusions, I think the majority of people get treated with high-dose oral. So you must interpret the data based on the healthcare system and the perverse, I call them perverse incentives, bringing people into hospital. So in the current COVID-19, there is no justification, and I agree with Joela, yeah, for bringing patients into hospital for infusions. The one exception, Joela, and I always, Freya, our MS nurse, always says this: if somebody's getting steroids for the first time and they live alone, and there's nobody to monitor whether or not they're going to get psychotic from the steroids, maybe it's a good thing to bring them in so you can just at least observe them on a daily basis to see they don't get psychotic, you know.
And there's also the diabetic effect. So obviously if someone has steroids inside the hospital, we can monitor their blood glucose, we can check. So there's all those monitoring things that can't happen if a patient's at home. And so it is looking at the patient as well.
Yeah, so I think you need to probably reserve the IV for those patients that are high risk, living alone, who can't be monitored for, who are getting it for the first time as well.
Yeah.
Okay? Particularly if you're worried about mood or psychosis. Okay. And believe me, high-dose IV steroids can cause both. It can cause a raised mood, hypomania and mania, and it can also, in some patients, be associated with severe depression. And also it can cause insomnia, and sometimes the insomnia can be quite profound. Okay. All right, Joela, which formulation?
So in the UK, we're lucky. We've got licensed tablets. It's annoying that they come in 500 milligram tablets because we're asking patients to take 5 of the 100 milligram tablets. But you know, we have a formulation that is licensed or able to use it. Obviously, I know in other countries they don't have access to these tablets, so they use the injection orally. It can be quite bitter, and so you can dissolve it in orange juice, and that seems to mask the medication flavor of it. And cost-wise, the methylprednisolone the tablets aren't cheap, but with it's a licensed product, it's easy to dispense. It's easier for patients to use. The vials aren't user-friendly to draw up the dose.
So, I mean, one of the things we've had, though, Joela, is a lot of the pharmacists, when you prescribe these into the community via the general practitioners, the local little pharmacists just don't have the high-dose methylprednisolone tablets available.
It's because they actually have quite a short shelf life as well. So obviously for most community pharmacies, they're not dispensing that much of it. There is the issue on supply chains with Brexit coming, with all of these things. A lot of commonly used drugs are having supply chain issues. So knowing alternative formulations is useful to know. Actually, you can use the vials orally if needed. So it's being aware that you can do that. Also, the BNF never used to say what the dose for a relapse was, and we've managed to finally get that added in, so that when people were seeing 500 milligram dose of methylprednisolone and they've never seen it before, at least they are aware, actually, this is okay, it's a regular dose.
So tell me, will the community-based pharmacists dish out the Solumedrol vials for patients or not?
There's no reason why they can't. It's not a hospital-only product, so if it was prescribed, it could be dispensed for a patient. The issue is going to be counselling the patient how to get the drug out of the vial, because it's needing a needle, etc. So it's doing that training for the patient as well.
Yeah. So I mean, my message to you is, and this happens all over the world, because in some when I trained in South Africa, we used to use the IV formulation orally. And Joela's right. We just used to mix it with a bit of orange juice and take it. And the pharmacokinetics in terms of the absorption is pretty as good as the tablet. Yeah. So it's the same compound. So I mean, I know in an ideal world you shouldn't be using an IV formulation orally, but it does work, and it's something you can fall back on, because Solumedrol, the IV formulation, is pretty much available everywhere. Okay.
And also, if someone has swallowing difficulties where tablets might cause issues, and actually if they're having to take 5 tablets, and they have any swallowing difficulty, there could be a problem. Actually, the Solumedrol might be a better option, because at least they can put it into a liquid preparation.
Okay. Okay, what about the infusion reactions? Can I have my treatment without steroids, Joela?
So obviously, all of the trials with all of the MABs, there is some risk of infusion reactions. But it's monitoring the patient with subcut preparations of any drug, so not just the MAB. You're less likely to receive an infusion reaction. So the subcut preparations that are either off license or are coming online, that does offer an option. But it's just monitoring the patient and being aware of what you're using and knowing that you're using it appropriately.
Yeah, I mean, just to say, I mean, Joela actually supported me on this. We had one particular patient who got psychotic on her first course of alemtuzumab. Really got quite badly psychotic, actually. She had to be put onto an antipsychotic medication. So when it came up for a second course, we actually gave the alemtuzumab subcutaneously. And to be honest with you, the oncologists have been using alemtuzumab subcutaneously for decades. And they can't believe we're giving it intravenously. And I actually contacted NHS England asking would they reimburse alemtuzumab if we did give it via the subcutaneous route. And they said, fine, you just got to make, they understand that you have to be pragmatic. And this patient got her second course subcutaneously without steroids. And she did well. She depleted and I must point out that there are studies in the literature showing that the pharmacodynamics in terms of lymphocyte depletion is equivalent whether you give the dose intravenously or subcutaneously. So much so that Genzyme at one stage was going to develop a subcutaneous follow-on compound, which they stopped because they didn't think the market would support it. But there's no reason why we can't give alemtuzumab subcutaneously. And you can avoid, and this patient didn't have any steroids, and she just had antihistamines, and she managed the subcutaneous injections without any significant side effects. Because I think alemtuzumab is our big worry, Joela. It's the one you can't really get away with without, the IV formulation.
Yeah.
Anyway, what about ocrelizumab? Should we be using steroids or ocrelizumab all the time?
Well, there is a school of thought that says, well, actually use it for first dose, so the week 1 and the second dosing of it, but actually for the 6 months onwards, do we really need to be using it? Question mark.
Yeah, I mean, so Anne Cross, who's got probably the most experience in the United States with anti-CD20, she's one of those MS neurologists that started using rituximab in the very beginning. And she never used to use steroids at all for rituximab. So when ocrelizumab came out with this pre-dosing with steroids, what dose do we use in our center? 125 or
yeah, 125. Yeah.
That's lower than the alemtuzumab dose, which is 500. Yeah. So she actually has stopped using with the subsequent doses, and she's actually she said to me, Gavin, patients don't notice they're getting it, and I think that's because they are still B cell depleted. So maybe we should, as a MS community, not be giving steroids with our subsequent courses of ocrelizumab. I don't think there's a need for it. So that's one way of avoiding the steroids. Okay. We haven't done that yet, have we?
No, not yet.
I think we should probably talk about it and implement it, based
on...
Yeah,
and also, do you think just on an infusion capacity, obviously with COVID and social distancing, it does mean patients will be in your infusion suite for less time, and that is also a bonus for patients?
I think we should do it as a service development, subsequent infusions, particularly in the current COVID-19, and based on other people's experiences, the biology of the drug, etc. It's not necessary. Just to say to you that when it comes to gastrointestinal bleeding, okay, you can see that methylprednisolone, okay, it's got a much higher risk compared to ACTH. We don't use ACTH anymore. Is that because it's too expensive, Joela?
Yes, basically it's too expensive, and now availability would be an issue as well.
Do you know how much it costs in the United States? Because a lot of people use it in the US, ACTH still.
I don't know.
I mean, it costs tens of thousands of dollars to treat a relapse with ACTH because of because it's licensed and there's only one formulation in the United States. So be aware, steroids are associated with gastrointestinal bleeding. This is just showing you psychosis. Okay. Also, there's a strong tendency to cause mood disorders. So just be aware of that. Okay. This is still crossing over the one, but there's about a 2.5 times higher risk of psychosis on steroids compared to placebo. The one that worries me the most, and I can't find MS data, Joela, most of the data comes out of lupus field,
Yeah.
high-dose steroids and avascular necrosis. But I can be honest with you, I've been in MS for 27 years now. So I started in 93. And I've got 5 patients, that have had bilateral avascular necrosis of the hip. I've had 1 patient who's had a single hip. I've had 1 patient who's had top of their tibia. And I've had 1 patient who's had vascular necrosis of the jaw, which was complicated by steroids and a biphosphonate. So I think the biphosphonate was probably the complication there. So it's not that uncommon. And to be honest with you, in our CARE MS1 and MS2 programs, and we had 2 patients who had bilateral avascular necrosis, and we only had 35 patients in that trial. So if you look at the literature from lupus, it comes in at about 1 in 120, but 1 in 80 to 1 in 125 get this complication. So it's not rare, it's quite common, and we miss it.
And so I do wonder, MS patients are then at risk of falls, and their stability and everything else is not right. So are we putting patients at undue risk by putting them on the steroid as well as this?
Yeah. And the one patient who got avascular necrosis in our alemtuzumab trial, he was actually randomized to rebuff. So he got the steroids to blind, as part of the. He didn't need the steroids for rebuff, but he was on rebuff, and he's about to have a hip replacement on the one side. So it's an issue. Okay. And anyway, I did a blog post on this a few years ago, and I actually asked patients. It wasn't I found this last night, and we only got 35 responses. But I must be honest with you, once you get over 30 responses, the results don't change much. But most patients were not made aware of the avascular necrosis of the hip. A lot of people weren't made aware of the avascular necrosis of the hip with steroids. Okay, is there an alternative to steroids, Joela? Do you think we should be exploring that in the current climate?
Plasma exchange could be an option, but the problem is obviously you're coming into hospital capacity issues. Even in normal times, we don't have capacity for plasma exchange in our hospital, it seems, for anyone outside renal, so it's always an issue.
Just to say to you that we had the one patient, she actually had neuromyelitis optica, one of our patients that in retrospect she should have been escalated to rituximab about a year ago, but she decided not to for various reasons, and she came in with a relapse during COVID. It happened quite early on in the lockdown. It was about late March or early April. We gave her 2 courses of high-dose steroids at home, and eventually she was still getting worse, and we had to bring her in for plasma exchange. And so the question I always ask myself, because she was quite bad and going off her legs, we should probably just brought her in and gave her plasma exchange from the beginning. But it's a soft call. I mean, that shows you how anecdote will affect my next decision. So we haven't had another case like that. But you can use plasma exchange, which is as good as steroids, or if not better. Anyway, I'm not going to go through these slides, but one of the things about plasma exchange is the Lazarus effect, particularly in patients with neuromyelitis optica or longitudinally extensive, is that when you start exchanging them, you probably be removing a blocking antibody, and a significant number of patients get up and walk literally within a day or 2 of starting the plasma exchange. And if you're interested in reading this editorial by Brian Weinschenker in the apheresis journal, Therapeutic Apheresis Journal, he talks about the Lazarus effect. I must be honest with you, from a personal perspective, it's not common. It's most patients with plasma exchange don't get up and walk. Okay, they take ages to recover function. Okay, so steroids during the COVID pandemic. I already mentioned this to you. Okay, so Joela, do you think this slide summarizes where we should be going?
Yeah, no, definitely. And I think everyone should be reviewing the use of steroids, but actually not just in the pandemic. Why are we putting people at risk when we don't need to, even non-pandemic times? Because we live, work in East London, and there are infections if you get on the tube. Why, it's not just COVID we should be trying to avoid.
Yeah, so trying to avoid it. Obviously, if you're going to be starting Ocrelizumab, I think you're obliged, based on the data, to give steroids for the first course.
Yeah.
But after that, I think you could probably get away with not giving it, and keep it in reserve. If somebody does develop an infusion reaction, you can give the steroids afterwards. You don't have to give it before. And with alemtuzumab, it's a little bit more tricky. My personal opinion, we should probably be reassessing the way we give alemtuzumab in the current environment and shift to subcutaneous administration without steroids and see how people do. Because one of the things is the shielding. Some people may not. Anybody who gets high dose steroids, our current advice is for them to shield for 14 days. Do you think that's the right time period, Joela? 14 days?
Yeah, I mean, it's 14 days because especially if I don't think a lot of patients aren't compliant on days 14. And also, we work in central London, and our trust, we're asking people, oh yeah, you can go and shield, but you have to leave this hospital, and often people are leaving by getting the tube. So our shielding, our rules are a bit questionable. It's like, well, actually, go and shield, but after you get home, after taking public transport, on probably the riskiest thing you're going to do. So it's a bit strange.
I think some of you may be looking at this list and saying, goodness me, you're using alemtuzumab. Yes, we are. We've actually made a decision internally that COVID-19 is not going to disappear necessarily in the next month or two. And we have to treat MS. So a lot of people are coming up for their second courses. Even some people want to start, and as long as they understand the risks, and I think the data out there is supporting alemtuzumab has not been as risky as people thought it would be. So we are now beginning to start alemtuzumab infusions again. Our problem in the past was really manpower and having access to appropriate infusion suites.
Yeah, and I think we would have started months ago if it wasn't for the infusion capacity. And I noticed Ellie's just asked the question, is it 14 days from the end of the steroid treatment? And I would say yes, it would be, because it's not like we're doing a tapering dose. We're giving high dose steroids on all of the days of the course of steroids.
So Ellie, you may have recognized that the Italian data suggested 28 days was the risk period, and we're saying 14. So, if you wanted to be really safe, you should say 28 days, because covering the infusion periods, based on the Italian data, if you want to be evidence-based. But I personally think and I agree with Joela, to expect people to shield for long periods of time is really, really difficult.
And you'd rather than be compliant with the shielding for 14 days and do 28 days and half shielding, and from day one they're not really following it at all. So, and also it's reminding people, so they might hear on the news, oh, shielding is paused. Shielding is paused for those that were on the government list back in April. Shielding in this situation isn't paused. So it's reminding them, despite what is said on the news, they are shielding because of an acute situation rather than long term.
I put this slide in just to remind people that this data is out there, and I think it's now been reproduced. So this is actually showing you that if you are on certain DMTs, you may have an increased risk of getting COVID-19 or severe COVID-19. And if you look at the top red bracket there, Ocrelizumab was positive in the so-called uni and multivariate analysis. Natalizumab was positive in the univariate analysis, but wasn't significant in the multivariate analysis. And actually, the bottom end, interferon and glutaric acetate, showed a lower risk of getting COVID-19 or severe COVID-19, and all the other DMTs fell in the middle. So I think the Ocrelizumab or anti-CD20 data is pretty convincing. Yeah. It's now been confirmed by the Swedes, it's been confirmed by the Iranians, and the Big Data Alliance, the consortium, presented at our MS Virtual 2020 on the weekend, showing exactly the same thing. So I don't think this should change practice, though, because the risk anyway is low. This wasn't associated with a high risk of death. So this was just a high risk going into hospital.
And I mean, it's only just to the right-hand side of the line. It's not like to the far right where the risk is massively doubled. And as you said, it's a low risk, which is increased. So it's still low. It's not, you're definitely going to get COVID. It's not so severe as that.
So I think my personal take on this is you should reassure your patients saying there's no significant increased risk. And anyway, when you double a low risk, you still got a low risk. I think that's the important. And also the other thing about Ocrelizumab, it had to do with the duration of treatment. The real risk was associated with people that have been on the drug for longer than 3 years. So in other words, what's happened in the past, you can't do anything about it. So even if you stop Ocrelizumab, it takes 12 to 18 months to get your B cells back. You're not going to change what's going to happen over the next. So there's nothing you can do about it. Okay. In terms of starting treatment, because it's a long term, I think it's going to be irrelevant to starting treatment because the risk will emerge over the next 3 years. So that's why I'm arguing it makes no difference to change your practice. Okay.
And I think it's advising patients and speaking to them about their individual acceptability of any risks. We should be doing that anyway, but it's making them aware and actually that making them make an informed choice.
Yeah. And also the way I'm beginning to understand it, it's becoming quite clear that there's a significant number of us in the general population that are resistant to coronavirus infection, or we have some kind of immunity to it.
Yeah.
And it looks like this may be related to cellular immunity and maybe a little bit of antibodies from previous coronavirus exposure. So having had that common cold or that infection, say, last year, has given you some cross-reactive immunity that protects you from getting severe coronavirus infection. So I don't personally think that the risk with Ocrelizumab or even Natalizumab, if it is there, is due to increased exposure to the virus. I think what happens is we've got reduced immunity from being on the drugs in the past, which basically reduces your chances, if I can just show it here with this pointer, of having it increases your chance of getting symptomatic infection. This actual graph is wrong because this box here is not increased. The death rate is the same. And so I think what it does is it slows down your ability to mount an immune response. But when you mount the immune response, you clear the virus and it protects you from getting the severe complications. So good news all round, I think. Yeah. Death. So Joela, what's your take on the factors that predict dying from
I think it's the comorbidities and also the treatments that were given to treat the COVID in these patients. If you think worldwide, actually the number of patients that are on DMTs or actually catching COVID around the world isn't as many as actually were worried about back in April and March of this year. But actually the patients have been treated differently. So if you go into hospital now, so you've got severe COVID now, and even in the NHS, we now have treatments that we can offer patients that means that you've got less likelihood of dying. So in these patients, I think sometimes we didn't have the treatment. Some of these patients back in April, March, people were using IVIG. This is not commissioned by the NHS for COVID, but there were different treatment options. So I don't think it's the DMT, and it might be comorbidities or how we're treating those patients once they're in hospital and once we're able to give them specialist care.
So in the French data, it was the opposite way around. People who weren't on a DMT were more likely to die, and I think that was the reason for that was those patients were much more likely to have advanced MS, progressive disease, old age, comorbidities. So I think the message then to our patients is your DMT is not an important factor. And I think there's biology around that. The DMTs don't impair the immune responses that target viral infections and severe viral infections. And what predicts poor outcome is really all those same factors that predict poor outcome in the general population. Okay, I think that's the take-home message. Yeah. Okay, so although DMTs do affect the benefit risks, I don't think the shift in the balance is sufficient to warrant us changing our practice. Okay. Joela, would you agree with that comment?
Yeah, and I would agree, apart from the only thing is to add into the discussion with the patient is vaccine response, because we're unsure yet at the moment what the final vaccine will be, when it will come. So you want to make the patients be more aware of that fact. I think if you start telling patients you're going to be taking immunosuppressant, in these times, those words mean something different. So people worry a bit more. So it's, you might want to be careful with the language being used, because actually there's a risk of getting COVID, but the patients have MS. So we do want to treat their MS rather than the potential risk of something else.
Yeah, I should have actually made this slide. This is a DMT slide. I should have actually tilted this the opposite way for steroids, because I do think based on what we've just discussed and the 6 times higher risk and the marginal benefits of steroids and the adverse events of steroids and the need to shield with steroids and all those things, I do think that this scale should probably tip with steroid usage. And so your decision to use steroids should be much more nuanced, and there's much more evidence against the unnecessary use of high dose steroids. So I think we're not saying don't use them. We're saying you should step back and ask the question: are they necessary? Does this relapse or justify this? And use them very sparingly and in very unique situations if you can.
We should be doing that. We should be trying to use them sparingly despite COVID. So even in normal practice, we should all be reviewing our use of steroids and not jumping to them as a first-line treatment, and like maybe no treatment would be an option.
Yeah, well, since my cluster of cases of vascular necrosis, that's exactly why I do it as well, Joela. I try and avoid steroids. Because some of those serious adverse events from steroids are unpredictable, and once they happen, you can't reverse them. Okay, so we already mentioned this. So, I put this up quite a while back. I prepared this slide, and I think maybe we should go through it. So, our current advice for self-isolation is based on government guidelines.
Yeah.
But in our MS population, I personally think that if people are worried, the people to shield are the ones with the older patients and the one with comorbidities. HSCT, is that an issue? Are we started again, Joela? I don't think we are.
No, we haven't. And even for the oncology patients, it's not been started again because of people worried about the risk. And MS will be much further down the line as a treatment option.
Yeah. I think the ABN guidelines have always worried about the lymphocyte depleting agents, but with the new data emerging, I'm not sure having a low lymphocyte count is necessarily a risk factor, to be honest.
No, I don't think I don't think it's as easy to measure the risk factors as easy as a blood count. I mean, it would be nice if it was, but it's sadly not the case. And I think it is individualizing that risk. And actually, if a patient is going to feel more at ease because they were told by Gavin, oh, actually, you're best off shielding, tell them to shield. If they're more anxious about going out, it depends what's going to cause them more anxiety.
Yeah.
Actually, if telling them to shield is causing the anxiety, it's risk benefit to their mental state as well as their physical.
So, I mean, the ABN guidelines says that patients who have been treated with alemtuzumab should shield for 3 to 6 months. To be honest with you, there's several case reports that have been published now of patients getting COVID-19 literally the week or two after having alemtuzumab. One patient had 0 lymphocytes, 0.0 in their blood. The other one had 0.1, I think, or 0.2, 200. Both those patients recovered without any complications. Yeah. So it just shows you your peripheral blood lymphocyte count is not a good biomarker for risk in young people. I'm talking about young people. I think if it was an older person, it would be different because then you've got other factors playing in older people. But in the typical MS population that are going to get alemtuzumab, which tends to be younger, well patients, I personally think we've overstated the risks.
But I think the problem with a lot of these guidelines, they were all written back in April, May, June, when there was very limited data. People were more scared because we didn't really, at that time, we didn't know what was going to happen. Was the NHS going to collapse? Is it easier for everyone to just shield and not cause any issues? I think there is a role for us all to review those guidelines and update them. So I know the ABN guidelines are up for review on the 1st of November, and there is that actually review the new data.
Yeah, so I've actually grayed out cladribine because we've taken the position based on data that, as you know, cladribine doesn't really suppress the T cell counts very much, which are the cells that are responsible for fighting viruses. That cladribine doesn't affect innate immunity to any significant degree as monocytes and neutrophils. So we've actually made the point that somebody treated with cladribine is unlikely to have any problems. And the data supports that. Merck presented all the cases reported to them. And there's also a lot of patients in the big data set and from Italy, and they've all done well. So cladribine, we took the position several months ago not to stop dosing and not to worry about redosing and not to shield.
And I think it's important that everyone does register cases of patients that have COVID, either diagnosed or suspected, and does put them on some sort of registry so that it can be add to the data that's out there in the evidence base. Because that's how we're all making these decisions, is based on the evidence base that's out there.
Yeah, and with alemtuzumab, we've also been a little bit less strict I'm telling our patients that they should try and self-isolate at least for the first 6 weeks, try and get it up to 3 months if they can. Because if you look at the trial data, the infection signal with alemtuzumab was almost all in the first 6 weeks.
Yeah.
Once you get past 6 weeks, the risk, apart from shingles, was very low for other infections. So I think once alemtuzumab treated patients get past that first 6 weeks, they're relatively safe. There's no way you're going to be able to tell patients to shield for 6 months. Impossible. We mentioned high dose, and obviously the symptom suggestive of COVID is to protect other people. I mean, that's nothing to do with MS. That's to protect the general population. What about steroids to treat COVID-19?
So everyone will have seen the reports in July where this wonder drug was going to cure everyone of COVID and treat everyone, and it was dexamethasone. And we're like, what? And so, yes, for severe to critical COVID, we are now using dexamethasone as a treatment for patients currently in ICU. So it should, but there are actually quite strict criteria. So back in July, there were countries around the world which are giving dexamethasone as outpatient treatment. So you were at home, had symptoms, didn't even have swabs that confirmed you had COVID. They were given dexamethasone as a treatment. To now to control the supply, because there is that issue, is are we going to run out of dexamethasone? Question mark. We need to control the supply, and actually the best evidence is in the severe to critical patients. So the patients needing mechanical ventilation, oxygen, etc. So it's not for if you've got mild symptoms and are able to manage at home.
So you can see in D, which was, this is the NEJM paper, no oxygen required, no difference. There's a trend, but no difference.
Yeah.
So Joela's right. If you're going to, dexamethasone is only really indicated in people that have got severe COVID-19 needing oxygen therapy. There's a question from Helen Willis. Is avascular necrosis linked to receiving a number of courses of steroids, or can it occur only 1 or 2 courses? Helen, you're absolutely right. It can occur after only 1 or 2 courses. So the patient of mine who got bilateral avascular necrosis of the hip in the alemtuzumab trial had 2 courses. He had 3 days of 1 gram in year 1, and then the second 3 courses in year 2. So yes, it can happen after very, very little exposure. Just to say to you that you can use IV or oral, and the dose, I think the dose in the trial was 6 milligrams a day. Is that right?
Yeah, 6 milligrams. And most hospitals will have a protocol for how they're going to use dexamethasone, and are they going to have to ration the use in other patients. We haven't got to that stage in our trust yet, but it's being watched quite closely, the levels of dexamethasone and steroids. Hydrocortisone is an alternative steroid that has been used, and there's evidence for that as well.
So guys are asking, do we know how to register COVID cases? So there's the MS registry study. So I think you just go onto the MS register, and there's a portal for entering the data. Guy. One of the UK sites is also participating in the database in Italy. I'm not sure which. I think it's Nottingham is participating in the Italian data set as well. Okay, so just to go through some of the things we've discussed, high-dose steroids likely increase your risk of getting severe COVID-19 if you do get exposed to the virus and you have MS. And that risk period based on the Italian set, it hasn't been confirmed yet, is based on the last 4 weeks. Try and avoid high-dose steroids for treating relapses if you can. First of all, they're not that effective. All they do is speed up the recovery. They don't alter the natural history of MS. The risk-benefit is finely balanced, and please don't forget psychosis, avascular necrosis, which are the 2 big worries. Obviously, hypertension, diabetes, all those short-term ones also need to be kept in mind. I think we made the case that orals should trump intravenous, except in a very small number of examples. Consider plasma exchange in patients with severe disabling attacks so you can avoid steroids. Reduce dose of methylprednisolone to prevent infusion reactions, and maybe alter the route of administration if you're worried. And during high-risk periods, recommend shielding for 14 days. Any other points you want to make, Joela?
No, but if you're having issues with supply of the steroids, etc., speak to the pharmacist involved. Because you don't want to hear about the steroid not being able to be supplied 3 or 4 days after it's been prescribed and the patient's taken the prescription to the pharmacy. So just speaking to your local pharmacy department or your community pharmacy about supply and getting patients to report back if they are finding issues.
Okay. No other questions. We finished early. No, we were meant to finish in 45 minutes.
So plenty of time. So if there's no further questions, then we can close the session.
So Joela, I mean, one question for you, steroid cards. Should we be giving people steroid cards with relapse treatments?
Yeah, so it does inform patients that they're at risk of things like that. If you know the patient's going to be shielding at home for the 14 days, and they don't need a steroid card, it's just to make healthcare professionals, if they're likely to have a dental appointment or go to A&E in that time, people are aware that they're on the high dose steroid. And so for a short course, it's not as a, but it's just so they're aware that they are at risk of things. It's down to individual patients. I know a lot of people just don't like carrying these things around with them. So it's just making them aware and making them aware that they should tell people if they've taken them and have to go to A&E for any other reason. Yes,
I think one of the big worries is really the suppression of the hypothalamic pituitary adrenal axis and the risk of an Andersonian crisis if you had a major stress. So if you suppress that axis for too long, then you can't make a stress response.
And a 5-day course is not the long-term courses of steroids that we're used to. If people were receiving the 5-day course repeatedly in a year, so I'm talking like 3, 4, 5 courses of steroids in a year, then we would be a bit more concerned. But also I would be more concerned about the prescribing habits of that prescriber as well.
Yeah, so I think if I remember correctly from general medicine, the pituitary adrenal, the hypothalamic pituitary adrenal axis, you need at least 3 weeks of relatively high dose steroids to suppress that. So Andersonian risk, you've got to be on it quite a long time.
Yeah, endocrine tend to say if you're on a high dose steroid for like 10 to 14 days, at that point start giving the steroid count. But before that, you don't need to worry. But it's the repeated courses that MS population might be worried about. But as I said, they shouldn't be happening anyway. So.
Okay, so the final thing would be, if you think steroids, step back and say, can I do without them? Okay, or do I have to prescribe them? I think just ask the question because of the risks associated with them and the relatively minor benefits of treating relapses with steroids.
But also having that discussion with the patient. So the patients, if they are coming expecting steroids, maybe no one's ever discussed with them, actually, the relapse is, you're going to end up with the same physician, just maybe a week or 2 later. So maybe and if they're not aware of the risks, it's a discussion with them to make it an informed consent procedure.